Hey there, and welcome to the third part of our series on renal and urinary systems and electrolyte balance for the ABA Part 2 Advanced Exam. We're going to briefly touch on acid-base and electrolyte disorders. A fair amount of this material was also part of the content outline for the basic exam. And again, the ABA doesn't expressly specify how much of or what the scope of each keyword you need to master for either exam. So we are going to talk about some of these things, and some of it will be redundant. Now, what's new is we're going to add in some of the urologic considerations that we undertake for anesthetic care. For these procedures, that is definitely part of the advanced exam, so we'll probably focus a little bit more attention on that. As far as acid-base disorders goes, I'm not going to do an exhaustive lecture on acid-base balance. By this point, you should have a thorough understanding of how to diagnose acid-base disorders. It all essentially comes down to identifying the abnormality in the pH, and then consequently in your decision tree whether or not the PCO2 is elevated or decreased, which helps you define whether you have a respiratory abnormality causing an acidosis or an alkalosis. Of course, you look at the measured bicarbonate as well, and you make your assessment of whether or not you have a metabolic acidosis or alkalosis. Now, certain values you should be aware of course, is the anion gap, which defines whether or not you have a metabolic acidosis, and that includes your sodium minus your chloride and bicarbonate. The normal value being about 8 to 12. And we're also going to talk a little bit about the delta gap and delta bicarb here in just a second. I would probably look through this chart that I made that shows you what the compensation mechanisms are for these different acidotic and alkalotic syndromes here. But the general trend that you can see here is that for a metabolic acidosis, a patient can efficiently hyperventilate to compensate for that. And so for every milliequivalent drop in bicarb, a patient can hyperventilate to drop their PCO2 by about a millimeter torr. With metabolic alkalosis, patients are less adept at compensating. They don't hypoventilate very well. So every rise of 1 milliequivalent of bicarb, you only get about a 0.6 rise in PCO2. So patients do alter their respiration in response to acidemia and alkalemia from a metabolic source, but they're much more capable of hyperventilating to treat or to compensate for an acidosis than they are to hypoventilate to manage an alkalosis. So now the reciprocal here is when you have a respiratory abnormality, you can have acute versus chronic. Let's focus on the acute. With an acute respiratory acidosis, you want to retain bicarbonate. And what you can see here is that your PCO2 has to rise by 10 millimeters of mercury before your body's able to retain about 1 milliequivalent per liter rise in bicarbonate. So the metabolic response to a respiratory abnormality is nowhere near as robust as the ventilatory response to a metabolic abnormality, and that should make sense to you. On the flip of a switch, you can alter your respirations to counteract metabolic syndromes, whereas primary respiratory syndromes, you're calling upon a host of factors like renal mechanisms and so forth, which are generally kind of slow, pretty sluggish in response to compensate for this. Now, once you get to a chronic acidosis, your response from the kidneys and systemically is a little bit more robust. You can get about a 4 milliequivalent rise in bicarb for every 10 millimeter mercury rise in PCO2. Now, with acute alkalosis, for every 10 millimeter mercury drop in PCO2, you can actually get a 2 milliequivalent per liter drop in bicarb. So this response is a little bit better than compensating for an acidosis, but not by much. And again, when you're developing a chronic respiratory alkalosis, the response gets a little bit better at about 4 milliequivalents, about the same as it does for a chronic respiratory acidosis. So, and over here it just shows you the relative change in pH that occurs when you have a change in PCO2, okay, and both in acute and chronic settings, okay. But you can see overall the idea being that patients are able to compensate for metabolic derangements way easier than they are for respiratory derangements. Now, basic tenet of interpreting acid-base disorders is that regardless of what your pH shows, if there is an anion gap, because you always calculate the anion gap regardless, if there's an anion gap, no matter what the pH shows, there has to be a metabolic acidosis. Okay, an anion gap essentially means you have a low bicarb. Okay, remember it's this quantity minus this quantity, and so if you have a low bicarb, by definition, you have an ongoing acidosis. Okay. And then you go to the delta anion gap, and that is basically your anion gap up here minus the normal, so minus 12, okay? And we'll get to that in a second. Here, you're also going to calculate the delta bicarb, which is your normal value for bicarbonate, 24, minus your measured bicarb. And what you do with these two values, you create a ratio, and that helps you further characterize what kind of acidosis you have, okay? Acidosis or alkalosis. If your ratio is 1 between these two, what that means is you have this going on. Basically, you have an anion gap here because this bicarb is low. Overall, that same bicarb is low down here as well. The two go down in concert with each other, and since the chloride remains relatively normal, your ratio is going to be around 1, okay? And that basically just resubstantiates that you have an anion gap metabolic acidosis. So that doesn't do so much for you. Now, if your ratio is far less than 1, that's where it gets a little bit more interesting. If your ratio is much less than 1, that means this number, okay, is much larger than that number, okay, up there in the numerator. So why would that happen? In order for this number in the numerator to become smaller, okay, in order for that to become smaller, that means that one of these components here, the sodium minus the chloride minus the bicarb, has to increase to compensate. So if you have a normal sodium and you have a low bicarb because you have an ongoing acidosis, but you have a hyperchloremia, that means that when you take this whole quantity, that number is going to be subtracted by 12. This whole number is going to be smaller overall here, minus 12, and that's going to give you an overall much smaller number in the numerator. Okay, so what that means is you have a concurrent non-gap metabolic acidosis, meaning you essentially have a hyperchloremic acidosis on top of your anion gap acidosis. Okay, so that's what the point is of calculating the delta gap and the delta bicarb. It does help you identify that hyperchloremia is there. Okay, this is one of a number of ways of doing this. And then lastly, if you have a ratio greater than 2, meaning this number is very large, that is significant for a metabolic alkalosis. Okay. So this is all probably getting beyond the threshold of detail that the exam will probably test you on, but just for the sake of completion, I did include it. So overall, hyperventilation is much more of a relevant concept to you, especially if you're doing neuro cases. It can lower your PCO2 to around 26 to 30 millimeters of mercury, can rapidly reduce intracranial pressure through vasoconstriction. You don't want to go any further than that because that would tend to reduce overall cerebral blood flow and oxygen delivery. Overall, a 1 millimeter change in PCO2 is associated with a 3% change in cerebral blood flow, definitely a number worth remembering. The effect is short-lived and probably doesn't outlast 24 hours. If you have a saline-induced metabolic acidosis, we well know that normal saline causes metabolic acidosis. Why does that happen? The main reason is hyperchloremia. And that's because, remember from a previous renal lecture, I believe from the basic exam, that chloride is passively resorbed from the kidneys, all of it. And because saline has so much chloride, 154 milliequivalents, all of that chloride gets resorbed back into circulation, but in an effort to maintain electroneutrality, bicarb gets kicked out, and therefore you develop an acidosis. The pH of saline doesn't help either. Okay, pH of normal saline is about 5.6, very acidotic, but the primary mechanism is the hyperchloremia. The most common ABG found in COPD. You should know this because it was asked on an exam in previous years. In routine COPD, okay, I suppose. Most common ABG findings are hypoxemia without hypercapnia, okay. Hypercapnia is alarming if it occurs in COPD because that's when your forced expiratory volume starts to diminish rapidly, okay, and that's where the patient really can't maintain eucapnia. They're basically on the road to ventilatory failure at that point. But hypoxemia without hypercapnia is the most common ABG abnormality found in COPD. The most common ABG found postoperatively in general in healthy patients is hypoxemia with hypercapnia because hypoventilation is the most common cause. So a few things about some electrolyte disorders and urologic anesthesia as well. I'm going to start with hyponatremia. Three broad groups of hyponatremia. You have pseudo-hyponatremia. It's not an absolute reduction in sodium, but rather a dilutional effect due to the presence of osmoles. The ones that have stars are the ones that are not measured typically, but you can measure glucose, of course, and lipids. But all these things will drag water into the system and dilute your sodium. You can have hypovolemic hyponatremia, which results in urinary losses of sodium and volume. A prototypical case here would be cerebral salt wasting, but it includes a much longer list of clinical syndromes that can cause this. And then hypervolemic hyponatremia. And this is where you have essentially an extraordinary dilution of sodium due to the excessive resorption of water. Again, the main syndrome to think about here is SIADH. So we'll get into this in just a second here. So symptoms of hyponatremia include anorexia, nausea, malaise, confusion, and altered sensorium. Eventually, it can cause alterations in respiration and bradyarrhythmias if it gets severe enough. Main, cautionary threat of clinical management would be to correct no faster than 1 to 2 milliequivalents per hour when you're treating hyponatremia, or 8 to 12 milliequivalents per day, because you don't want to alter the balance of water as it translocates between the circulation and the brain in response to the instantaneous concentration of sodium in the system. Because if you are severely hyponatremic and you give a load of sodium, okay, that's going to essentially drag a lot of water back out of the brain and result in central pontine myelonolysis. Of course, in acute hyponatremia, if it's occurred very rapidly, the brain hasn't necessarily adapted to that yet, and so you probably have a little bit more margin of error in terms of aggressively treating it. So, as I said earlier, the brain adapts to the decreased osmolality and decreased sodium by decreasing its own internal osmolality, initially through the loss of sodium and other electrolytes, but chronically there's also the loss of neuronal osmoles, false amino acids like taurine and things like that. And again, if you rapidly correct, the brain doesn't have a chance to catch up, and you load the patient with all the sodium, it's going to drag water out of the system, out of the brain, and cause myelonolysis, which, because of the watershed region and sensitivity of the brainstem and the pons, that's where it occurs most readily. So moving on to cerebral salt wasting versus SIADH, and then eventually DI as well. Both cerebral salt wasting and SIADH present with hyponatremia, but through completely different mechanisms. Cerebral salt wasting, due to the result of the release of brain natriuretic peptide from brain injury, what have you, results in a primary loss of sodium, and water follows. So your patient tends to be hyponatremic, but also be hypovolemic because of that water loss. Whereas with SIADH, which can also occur with brain trauma, brain injury, and status post-neurosurgical surgery, when you have an inappropriate release of vasopressin from the pituitary, you get a net free water gain through those aquaporin channels in the distal collecting duct. In that case, you have a dilutional hyponatremia, but your patient tends to be hypervolemic. And so I put this slide up here, which I want you to spend some time looking at, okay? And I'll focus initially on cerebral salt wasting and SIADH. You can ignore DI for a moment. I put this up here because in a clinical STEM, whether it's on your advanced exam or in the oral boards, they're going to give you a parameter that will point you in the direction of one of the two syndromes, and you have to figure out which of the two it is based on other indices and how to treat it. So if you start with cerebral salt wasting versus SIADH, the clinical stem is going to give you a patient that's hyponatremic. So when you see low sodium, you immediately have to think of one of these two. There's a variety of things that can point you in the direction of one versus the other. With cerebral salt wasting and SIADH, you can't, of those things, you can't use urine sodium, urine osmolarity, or serum osmolarity, because those tend to be kind of the same between the two. However, with cerebral salt wasting, you will have a higher urine output, okay? And that is in contrast to SIADH, which you have oliguria, because you're resorbing all that free water at the collecting duct. So that's one indication that you have one syndrome versus the other. The other is extracellular volume, as I said. Cerebral salt wasting, you're hypovolemic. SIADH, you're hypervolemic. So these are the two things you would assess to differentiate between these two when the stem presents with hyponatremia. Okay. So, really keep it simple so that you don't sort of get psyched out about all the different derangements that can occur with sodium, either in the oral boards or in the advanced exam. Now, bringing DI into the mix, this is a little bit simpler because DI is essentially the opposite of what's happening with SIADH. But the way they're going to present it in the stem is not so much with sodium. If all they did was present with hypernatremia, you pretty much know you're probably going to end up dealing with a stem covering DI, okay? But that's not what they're going to do. They're going to present a patient who's polyuric, okay? So with polyuria, you might think DI, diabetes insipidus, but it could also be cerebral salt wasting because of that release of brain natriuretic peptide. You don't really know. But the nice thing is you can use virtually anything to differentiate between the two, like sodium concentration, which is very low, plasma sodium concentration is very low with cerebral salt wasting, as versus diabetes insipidus, where it's kind of high. Urine sodium, urine osmolarity, serum osmolarity are all going in the opposite directions between DI and cerebral salt wasting. Overall, both syndromes present with patients that are relatively hypovolemic. So just remember how they're going to present in the stem in these purple boxes between these two, and then the parameters you can use to differentiate between these diagnoses. So, all the following are appropriate treatments for diabetes insipidus, except which one? Choices include demeclocycline, hydrochlorothiazide, chloropropamide, or carbamazepine. So of all of these, demeclocycline is not used to treat DI. Okay, that's actually a treatment for SIADH. Chloropropamide and carbamazepine, okay, will help release arginine vasopressin and increase sensitivity. So those are appropriate choices for DI. Okay. But hydrochlorothiazide is kind of an interesting treatment. It is indicated for DI, but why would you give a diuretic to someone with DI? Because with DI, you're already polyuric. I looked this up a long time ago. It's kind of a weird and sort of wacky sort of mechanism that they describe. Not sure how much faith I have in it, but like I said, it's an older recommended treatment for DI. And the idea is that the antidiuretic action of thiazides is secondary to increased renal sodium excretion. The renal sodium losses cause extracellular volume contraction, leading to lower GFR and hence less delivery of fluid volume to the kidneys, and therefore less water and solutes are delivered overall that can be lost in DI. So it's kind of a backwards way of doing it, and in the end you are still giving a diuretic, so probably not the most obvious or first line choice of therapy. But technically speaking, yes, it is an approved indication for the use of hydrochlorothiazide. So here in this slide, what we see is a comparison of DI versus cerebral salt wasting and SIADH. With DI, particularly if it's central, it's pretty easy to treat. You just give them arginine vasopressin, ADH, through the IV. You can also treat, as I said, if it's nephrogenic, with a thiazide diuretic, chloropropamide, or carbamazepine. Cerebral salt wasting, you just give them what they don't have, which is some isotonic saline, and that should restore their volume and their sodium. With SIADH, you can treat initially with IV fluid restriction. You do Lasix diuresis, treat with lithium carbonate, which will inhibit ADH release, as well as with demeclocycline. can dialyze these patients. And a newer class of drugs are the Vaptans, or Conivaptan, Tolvaptan. These are ADH receptor antagonists that can antagonize the effect of ADH at the collecting duct. The anesthetic implications of someone who's hyponatremic include a decreased MAC, cerebral edema, central pontine myoanalysis if there's overly rapid correction, fluid overload, and, as I said earlier, arrhythmias can occur if it's severe enough, as well as with seizures. Hyponatremia is sort of a classic electrolyte abnormality intimately tied to older TURP procedures, open TURP procedures. Okay, so we are going to talk about this. You don't see classic TURP procedures being done too much anymore these days, but the physiology of it is good enough that the examiners still write questions about it, so it's worth knowing about. The reason that urologists couldn't use normal saline as an irrigation fluid when they did transurethral resection of a prostate is because the electrolytes in the saline would disperse all the electrical energy when they used cautery. So they had to use non-electrolyte containing solutions like glycine, sorbitol, mannitol, things like that. And unfortunately, when they used these solutions, they would cut through the prostate and open up the venous sinuses, and all these solutions would enter circulation. And of course, these solutions are not containing any electrolytes, so you're essentially absorbing free water alongside these osmoles, and that leads to hyponatremia, and as well as a host of other problems. With glycine's inhibitory neurotransmitter, which has been implicated in the transient visual loss associated with its use as an irrigation fluid, also gets metabolized to ammonia. So overall glycine toxicity can be a problem. That's the most commonly used of these irrigation fluids. Sorbitol is a sugar, and through its metabolism can cause hyperglycemia. Mannitol, of course, expands circulatory volume and then acts as an osmotic diuretic. So overall, the implication of doing a classic TURP procedure with any of the variety of these irrigation fluids is that you can have circulatory overload, the excessive intravasation of irrigation solution in free water, which can develop into hypertension and bradycardia through compensatory mechanisms. If it's enough to cause LV dysfunction, the patient may become hypotensive and pulmonary edema may develop. Management of this includes fluid restriction and loop diuretics and halting the procedure as soon as possible. Hyponatremia may occur because, like I said, you're diluting the circulation with non-sodium containing fluid, which can ultimately lead to cerebral edema if severe enough. And the CNS effects, in order of increasing severity, are restlessness, agitation, and confusion, which you may not see, of course, for patients under general anesthesia as versus a spinal anesthetic, and, of course, seizure and eventually coma. Cardiovascular effects tend to manifest once your sodium levels drop to about 120 or less and can include hypotension and arrhythmias. Again, managing these patients includes loop diuretic diuresis. Okay, severe cases may require controlled mechanical ventilation and inotropic support with serial evaluation of sodium concentration, and you don't want to rapidly correct the sodium if you can avoid it. Glycine toxicity, as I mentioned, it's an inhibitory neurotransmitter. It manifests primarily with CNS toxicity and transient visual disturbance. Okay. So any sort of visual disturbance after a TURP mandates immediate attention and a consult from the ophthalmology service. Other causes of perioperative visual loss must be entertained as well, such as stroke, ischemic optic neuropathy, corneal abrasion, and acute glaucoma. Ammonia toxicity may also result because it's a hepatic metabolite of glycine metabolism with excessive absorption of glycine solution. And ammonia toxicity can result in altered sensorium and depressed mental status, and that ultimately leads to your oversight of the patient's ventilation and hemodynamics. Now, bleeding and coagulopathy is another consideration for doing transurethral resection of the prostate, partly due to the fact that you are cutting through a lot of prostatic venous sinuses, but there's a higher rate of fibrinolysis that occurs with this procedure because you are releasing urokinase from the prostate gland, and that can lead to DIC eventually. So, because of that, we do take into account bleeding risk whenever someone's getting a TURP procedure. Moving along with other implications of TURP procedures, bacteremia and sepsis may occur, as bacteria may be introduced directly into circulation through open prostatic venous sinuses. And of course, the symptoms are what you'd expect for someone developing ongoing bacteremia or sepsis, and institution of broad spectrum antibiotics is indicated. So prostatic perforation can be an issue during these procedures as well. Inadvertent bladder perforation with the resectoscope can lead to extraperitoneal leakage of irrigation fluid. And intraperitoneal leakage may also occur depending on the location of where the perforation is. So extraperitoneal leakage results in pain around the umbilical area, inguinal area, or suprapubic area. And the surgeon may note an irregular return of the irrigation fluid. Intraperitoneal extravasation of fluid would result in upper abdominal pain or referred diaphragmatic irritation, which results in shoulder pain. The patient may become hypotensive. The signs are only reliable if you happen to be doing a spinal anesthetic if you're under T9 sensory level. Otherwise, you won't really be able to tell. Small perforations can be managed with catheter drainage, but large perforations ultimately require an open procedure for repair. More urologic considerations for the Part 2 exam include management of nephrolithiasis. Which of the following is an absolute contraindication to shockwave lithotripsy? Very similar to a question that was asked in previous years. Your choices include a patient with a large aortic aneurysm, patient on Plavix therapy, patient with untreated UTI, patient with implanted pacemaker ASCD. So anybody with a bleeding diathesis, you shouldn't be doing shockwave lithotripsy. So the patient on Plavix therapy should not be undergoing this procedure. Okay, you can do extracorporeal shockwave lithotripsy on patients with aneurysms. You have to be cautious about it, but you can do it. If the patient has a UTI, that may be okay to do this procedure because remember, a lodged stone can act as a nidus for infection in and of itself. So you really want to remove the source. Okay. And you can do these procedures in patients that are pacemaker dependent. You have to turn off the AICD. But with the pacemaker, you can also gate the shock waves so that they don't develop an RNT phenomenon and send the patient into a malignant arrhythmia. So overall, you can attack a stone a variety of different ways. You can do, like I said, extracorporeal shockwave lithotripsy, cystoscopy with a direct stone extraction and placement of a stent, laser lithotripsy once you get all the way up into the ureter, and a percutaneous nephrolithotomy, which requires prone positioning and access to the renal hilum. Now, the shockwave lithotripsy procedures rely on high-energy, repetitive sound waves that are focused directly on renal calculi, which basically fragments the stones. Tissue destruction around that area can occur, and normally does occur, and you can get hematuria as a common byproduct of doing this procedure. So it's not uncommon at all to have hematuria after this procedure. But you do worry about capsular hematomas of the kidney, injury to the bowel, things like that. Overall, bruising and ecchymosis of the skin may also occur. And like I said, a large perinephric hematoma may warrant further attention. Now, a patient with a history of dysrhythmias, pacemakers, or internal cardiac defibrillators can develop worsening arrhythmias induced by the shock waves. So you want to synchronize the shock waves to about 20 milliseconds after the R wave from the ECG, which corresponds to the ventricular refractory period and decreases the incidence of arrhythmias during as well. So absolute contraindications to shockwave lithotripsy include distal obstruction to the renal calculi. So you don't want to bust up a stone when there's already a further downstream obstruction. Bleeding disorder or anticoagulation in pregnancy. Relative contraindications include large calcified aortic aneurysms that are in the way. Untreated urinary tract infections. So long as you have treatment ongoing, and certainly if the stone in and of itself is the reason for the infection, you can proceed with caution. Again, pacemakers can be used safely so long as you understand the concern with gating the shock waves so that they're out of range of the RNT phenomenon. morbid obesity. It's not exactly contraindication, but the effectiveness of all that acoustic impedance for as well may be of question. A couple of things about hypokalemia. The board has asked a few questions related to hypo and hyperkalemia. Although it's included in a different lecture from a different presenter, you actually should review periodic hypokalemic paralysis and as well hyperkalemic periodic paralysis as well. For whatever reason, someone is on a kick for answering or asking questions related to those syndromes, even though you so rarely see it. Okay, but oftentimes the exam will give you sort of case stems and then move into their keyword with your answer choices. In this case, you have someone who has a history of hypertension, is on hydrochlorothiazide and potassium supplementation. And as it turns out, her last measured potassium was 2.7. What is the most appropriate management? Well, hypokalemia is a problem because, of course, potassium plays an important role in heart muscle function, muscular function. You can get electrocardiographic changes like a flattened T wave, depressed ST segment, and the appearance of U waves. As severe enough, it can develop into ventricular fibrillation or torsade. Skeletal muscle weakness is common with low levels of potassium. Gastrointestinal motility is slowed, which puts these patients at risk for regurgitation aspiration. And you can get bladder dysfunction and urinary retention as well. Now, if you have concomitant hypertension, that suggests excess mineralocorticoids. Remember, hyperaldosteronism basically intravasates sodium at the expense of potassium. And so you'll get hypokalemic, but with all that sodium and water coming back into circulation, you'll develop hypertension as a result. So in that stem, would you treat with potassium? I think most of us would. Interestingly, if you dive into Big Miller and look at what happens with pre-existing deficits of potassium or hyperkalemia preoperatively in elective patients, they actually recommend that they wouldn't necessarily recommend delaying surgery if the serum potassium level is above 2.8 if, and here are the qualifiers, the cause of the potassium imbalance is known. In this case, it's a diuretic, and the patient is in otherwise optimal condition, meaning they don't have any manifestations or symptomatology associated with the hypokalemia, and they don't have any abnormalities on their EKG. Okay, those things are in order, then it's actually fairly safe to proceed. In fact, there seemed to be more risk with running in a potassium rider rapidly to treat this level of potassium, more so than leaving it alone. So that's from Lee Fleischer's chapter in Big Miller. Correspondingly, with hyperkalemia, they recommended the same thing. If you're below 5.9 and potassium imbalance is known, the cause is known, and the patient is otherwise optimal condition with no symptoms, no EKG changes, it appears safe enough to proceed. Of course, all that has to be qualified. I mean, if you're using succinylcholine or planning to use that, for example, that may alter your decision making on this. So I'm not going to give you an exhaustive review of hyper and hypokalemia. Remember, review hyper and hypokalemic periodic paralysis. That keeps showing up on these exams for some curious reason, as well as TPN considerations, which I just wanted to put this slide in here so you're aware. Major metabolic concern with initiating TPN is hypophosphatemia. Okay. And the reason for that is because these patients have typically been NPO, they haven't had a lot of nutritional support, and so they're hungry for the formation of ATP. So the second you give them TPN, you give them enough nutritional support that they start leaching phosphate from wherever they can and to form ATP, and they end up becoming hypophosphatemic. The major metabolic concern with discontinuing TPN, is hypoglycemia, because TPN contains both insulin and a glucose source, and when you cut it off, the insulin tends to outpace the glucose source, so the carbohydrate component of TPN, because you typically give insulin alongside the TPN, and so therefore you're in this sort of phase where the insulin is still there but the carbohydrate isn't, and you end up getting hypoglycemic. Respiratory quotient is reflective of overall systemic metabolism, okay? And they have had asked questions about the respiratory quotient related to TPN, total parenteral nutrition, on the boards in the past. So a respiratory quotient, which is essentially the production of CO2 divided by the O2 demand, okay, or the consumption of O2, which is usually 0.8 in most patients, because you produce about 200 cc's per minute of CO2 relative to about 250 cc's of O2 consumed per minute in the average 70 kilo male. If your quotient is much higher than 1, okay, while you're on TPN, that is very suspicious for excessive CO2 production because of large carbohydrate loads being converted to CO2, okay? The implication with the respiratory quotient much less than 0.7 while on TPN will point you in the direction of potentially fatty liver or ammonia toxicity, because most of your calories in this setting are probably coming from lipids and amino acids. So if someone's on a TPN solution where they have very little carbohydrate, they're basically on a ketotic diet, and your respiratory quotient is going to be very low. But you do have to explore the possibility that they're developing fatty liver because of those excessive lipid loads. So what are the manifestations of hypophosphatemia? Overall, hemolytic anemia, heart failure, tachypnea, CNS dysfunction, including seizures, and eventually it can progress to death if low enough. These are complications of hypophosphatemia when you initiate TPN. So some practice questions to finish up with here. All the following metabolic derangements are seen with severe Addisonian crisis, except for which one? Hyperkalemia, hypocalcemia, hypoglycemia, hyponatremia, and metabolic acidosis are your choices. So remember that with Addisonian crisis, what you have is a lack of mineralocorticoids, a lack of aldosterone. So you don't have any return of sodium and water into circulation, and then you end up retaining a lot of potassium and acid. So you develop a hyperkalemic metabolic acidosis. You tend to be relatively normal calcemic or hypercalcemic to some degree in Addisonian crisis. And because you don't have enough glucocorticoids, your glucose tends to drop. Okay? And because, like I said, you're losing all that sodium in your urine, you tend to become hyponatremic. Which of the following is the most appropriate treatment for the condition shown below? And again, you're going to invariably get some sort of EKG to interpret on Part 1 or Part 2 exam, or even both. They want you to be able to do this. And in this case, what you see here essentially is hypokalemia that needs treatment with calcium gluconate or calcium chloride. And the reason that's the case is you see a very prolonged QT interval, okay? And that is highly suggestive of hypocalcemia. Sodium polystyrene sulfonate is used to treat hyperkalemia, okay? And you don't see peak T waves here with that. Pimidronate is used to treat hypercalcemia, as is saline and furosemide. You can use a saline diuresis to treat hypercalcemia as well. In that case, you would see a shortened QT interval. So I know this particular lecture was kind of a little bit all over the place here because, I mean, quite frankly, acid-base disorders, electrolyte disorders, urologic anesthesia, I mean, this encompasses a full day's worth of lectures. So I wanted to sort of target those areas that have been definitively tested in the past on the exam, and that's always been my approach, is to teach more towards the exam, because a lot of this information is something that is material you already know, but the board has a funny way of asking questions in very obscure ways, in ways you don't really typically think clinically. So therefore I wanted to focus on those items more so than anything else. So thanks for listening.